Now I invite Dr. Anju. She is a consultant oculoplasty in Comtrist Eye Hospital. She's my colleague. She'll be talking on evisceration, enucleation. Over to you.
Yeah, so once again, good afternoon to everybody. Actually, this is mainly intended at educating the general ophthalmologists, while I see the majority are oculoplastic surgeons. So it will be more an interactive one where you can add in your points at the end. We'll quickly run through evisceration and enucleation. So, enucleation was the oldest surgery performed in ophthalmology in the 2600 BC. So later in the 19th century, that was when Baer introduced evisceration, when he encountered an expulsive hemorrhage. Not very soon after, Noyes described evisceration for the management of intraocular infections. And a decade later, the first implant was placed, which was a glass sphere into the eviscerated cavity. So this Shebin already beautifully described about how we have the orbit, the eyeball, and the other contents, and how we need to know the volume that we need that is there, and how much we need to replenish. So about enucleation, it is a surgical procedure which involves removing the entire globe and its intraocular contents, preserving all the other periorbital and the orbital structures. So you can see how the structures which are indicated in blue and violet are the ones that are being removed. The primary indications of enucleation are intraocular tumors, especially choroidal melanoma and retinoblastoma group E, which do not respond to other treatments. And trauma, we generally do not do an enucleation unless and until the globe cannot be salvaged. And painful blind eye conditions, but now it is a relative indication. Yes, of course, as part of an eye donation, we remove the entire globe. It is contraindicated when you have an intraocular malignancy with evidence of orbital spread. In that case, you should consider an exenteration. What are the prerequisites? So when you have a patient who you're likely to advise an evisceration, we need to have an imaging in the form of an ultrasound B scan or an MRI. B scan is available right there in most of our hospitals, so you can get a good idea about the intraocular contents. Also, you can measure the axial length. And the axial length, when I say that, we need to measure the axial length of the other eye because it will guide us as to what size of implant that you need to place. And it is always important to take at least two ophthalmologists' opinion because this is a cyclodestructive procedure and there are medico-legal aspects to it. Like I said, an informed consent, detailed preoperative workup, general anesthesia if it's a child or if the patient has low tolerance to pain. You can also add sedation to your local anesthesia. They need to stop antiplatelets and NSAIDs prior to the procedure to avoid intraop and perioperative bleeding. And a detailed psychological counseling is very important because the patient is ultimately losing an eye. So we need to empathize with them and also tell them what they need to expect and do for their lifetime. This is a quick surgical video which shows enucleation by the myoconjunctival technique. So you begin by so before you begin the procedure, always do a timeout. Make sure that it is the right eye. It needs to be dilated and you need to ensure whether your diagnosis is right before you carry on with the procedure. So in order to reduce the bleeding, you can always go ahead and put in topical brimonidine. A 360-degree conjunctival peritomy is done and then the tenons are separated. Then you begin by tagging your rectus muscles one by one. So make sure that you tag them at least 2 to 3 millimeters away because in most cases you're dealing with intraocular tumors. You do not want any inadvertent injury to the globe. So after tagging all the 4 recti muscles, then the oblique muscles are then identified and disinserted. So gently by with the help of enucleation scissors, you strum the optic nerve. We go all the way up till the orbital apex, but we do not cut there because if you are to cut there, then you are likely to damage the structures at the superior orbital fissure, which can lead to intractable bleeding as well as post-op nerve palsies that can occur. So after this, the closure of the conjunctiva and tenons are also done. And this being a myoconjunctival technique, the recti muscles where we had initially tagged are now being taken through the conjunctiva. This is done to ensure that the patient has prosthesis mobility in the post-op period. So histopathological examination, it is important. Whatever structure that we remove from the body, it's always better to have the backing of a histopathological report. You need to know the extent, and that might alter your management. Postoperative care is pretty much the same both in enucleation and evisceration. Oral analgesia. You can give broad spectrum antibiotic prophylaxis if you're dealing with infection. A pressure patch would take care of the initial edema. You can take it at 24 hours, 3 days to 1 week, and then amp up with topical antibiotic and corticosteroid drops. Coming to evisceration, it is basically the removal of all the cornea and all the intraocular contents, leaving behind the sclera and the other structures of the eye. So indications, the absolute contraindication is by now, which you are aware, it's the intraocular tumors and those with orbital spreads. The rest of the indications are endophthalmitis, when you have a painful blind eye, phthisis bulbi, especially for cosmetic concerns. So evisceration consent form similarly, so not just one in English, you should have one in the vernacular language as well, because you need to make sure that the patients know what they're undergoing. So this is a step-by-step pictorial representation. So steps are more or less the same in the beginning, where you take a 360-degree conjunctival peritomy. After that, a stab incision is made into the cornea, and whereby the cornea button is then taken out. Then with the help of an evisceration scoop, you can scoop out all the contents. And it is very important to make sure that you have devitalized the uveal tissues, so make use of alcohol swabs and wash them thoroughly without touching the rest of the tissues outside. And once this is done, then the next thing is to make your petals. So now the common trend is towards a 4-petal technique, wherein the optic nerve is being disinserted posteriorly. This is to give more volume and also to avoid bleeding from the vessel supplying the optic nerve. And then the flaps are fashioned in such a manner that the rectus muscles are attached to each of the flaps. They are then closed by double breasting technique. We can use 5-0 vicryl, and then the conjunctiva is closed using either continuous 6-0 vicryl sutures or interrupted as per your liking. So a couple of things when you do this: minimum handling of the tissue. Make sure that you do not crush the tissues and cause inadvertent damage, because we need to preserve as much conjunctiva as possible. Any unnecessary meddling is going to cause you a contracted socket, and that will impede the fitting of a good prosthesis. And at the end of the procedure, always keep in a conformer so that the cornices are maintained. So I'll be skipping this technique, the video, in interest of time. A specimen examination, I like to send all the specimens for histopathological as well as microbiological, especially when you're doing it for an infection. So quickly about implants. So you're basically trying to replace a missing biological structure, and orbital implants are used to give that volume. So 70 to 80% of the globe volume is what you want to replace. Quick calculation would be for enucleation, axial length minus 3 millimeters, and evisceration will be axial length minus 2 millimeters. You have varying sizes of sizes that are available, which will give you an idea as to what implant size you need to put in. So there are various types of implants that are available based on the porosity. You have porous ones and non-porous ones. And you also, the biogenic implant that we have is the dermis fat graft. So just quickly about orbital implants based on integration. You have non-integrated, integrated, and quasi-integrated. So non-integrated ones are where it is a well-rounded implant and the prosthesis is just placed over it. Whereas an integrated one is where you use materials. So in a non-integrated one, you have the PMMA silicone, and in integrated, you have hydroxyapatite, which is porous, and it is a second step procedure wherein you have to do pegging and then place your prosthesis. And quasi-integrated is where you have prosthesis such as the Allen in Iowa, which have indentations on them, which will give quasi-integrated feel, and accordingly modifications are made in your prosthesis as well. So complications, pretty much Sheben has already covered most of this. I'll quickly run through this. So these were just our patients who had undergone evisceration and enucleation and who are fitted with prosthesis, and Celia will be talking to you in detail about that. Thank you.